Does it have to be recorded? Oh, hi, Karen.
Hi, Tobi.
I mean,
Nice seeing you.
With Melissa because it didn't
Okay, go ahead.
Hillcrest.
Go
Can we?
some people have called in advance and asked if we'll have a recording since they won't be able to watch it. But anything that we record, we usually record the programs. Anything we record is it's not sent out publicly. It's usually by
No, because we're recording right now as I'm speaking with you. So it'll be fine. Whatever. We'll deal with it.
I'll edit this out. Don't worry. Before
Okay, fantastic.
they will make the class the program that they really wanted to watch.
Okay, that sounds great. Okay, perfect.
Thank you so much.
Okay, thank you, Melissa. Okay, thank you. Bye-bye. Sorry about that. It's just,
That's okay.
now I'll tell you what happened. She assigned me to be the host, right? And log in under the Hillcrest Jewish Center. The
Yes.
problem is that it asked for a one-time passcode that was sent to the email. But so I couldn't do that. You know what I'm saying? I couldn't do that at all. So that's what's going on.
Okay, well, that's why Melissa does these things and not me, because I'm lucky I click on and I get a screen going here.
Right.
But I did have a few people ask about the recording this morning. They called me because
Yeah.
other things that are happening and they just won't be able to log on.
No, that's fine. So it's already recording already.
Yes,
So
see it
everyone's going to get this whole conversation beforehand. So it'll be fine. It'll be fine.
Okay,
So there's a lot to talk about, but I don't want to talk so much. So what I'm going to do is I'm going to talk and then I'll take questions from people
perfect.
because I want to be mindful of everyone's time, you know?
That's okay. We usually have the speaker for about an hour or so,
Mhm.
you know, depending, or a little less, and then questions and
Yeah.
answers. So
So-
before you call for questions, I just want to, I have something written I wanted to say. So I'm going to introduce you, then you will
Then I'll start.
continue, yes, with the program, and then I'll say one or two things, and you have, I hope everybody has a lot of questions. I have a lot of
They may
questions.
not. Like, the thing is, a lot of things, and I'm going to just say this right now, a lot of things are, we don't know yet.
Yeah, unfortunately, I know.
We don't know yet. I'm just going to bring my coffee.
That
So
go right ahead,
Right back.
go right ahead. Hi, Bertha, you're muted.
I may have to take me off video because I have somebody working here. And so be
Okay.
back.
No, that's totally fine. That's totally
Not
fine.
a problem.
That's why I'm on iPad instead of my usual computer.
No worries. Let's see.
Okay, so let's see what's happening. So, hi, Adele.
Hi, how are you?
I'm good.
Hi, Adele.
How you doing, Bertha?
I'm doing.
You doing? Okay.
I'm going later for my shingle shot.
Oh, I have to do that too. I haven't done it. I don't know.
Oh, so I'm not the only one.
No, I did the first one years ago. They didn't have the serum for the second one, and I just lost track of it. And when I went to CVS, they said to me I had to start all over again.
Yeah.
Yeah, and the new formulations are different. So
Yeah,
it's the Shingrix.
right. Yeah, so I do have to do it. I finished my boosters and my flu, so it's time for the shingles.
Yeah. I
Right.
did that too. So now I decided I'll do this one and then that's it.
Okay, yeah, I hope so. Well, we'll probably have a flu, COVID in the fall. They'll probably combine the two and we'll just have it all together.
Yeah, we're having it now. So
Yes. Yeah, you can do both together, they say.
Right,
Yeah.
right,
I didn't, but they say you can.
right,
Yeah.
right.
Okay, so I had the Shingrix in 2019, both shots. I think I'm covered for a while.
Oh,
Yeah.
yeah.
Yeah. My neighbor's very nice. She's taking me.
Where are you going? CVS?
Actually,
Hello.
Hello.
Hi, Elaine. I think I just
Hello.
saw you.
Hello,
Yeah,
everybody.
I think so. And I saw,
Hi,
you saw
Sandy.
my sister too.
Yes, right. Well, I'm only seeing a few, but let me see who's on here. So usually I get the recording of the rabbi's class because I'm playing mahjong Monday afternoon.
Oh,
Did he have the class already?
Yes.
Well, at 11 because he was on my time.
Oh, that's right. The
Right?
nerve of it.
No, okay.
Well,
did you
12
go to-
o'clock is the usual time he has a class. But I changed it because of today's meeting.
oh, we could have had it later or at a different time, but I guess this was the time that was
Well,
selected.
the Sisterhood always has their programs Mondays at 12:30. So I like to keep it like that, so people write it down ahead of time, and once
And
you
that they
start
know.
changing, you lose people.
Right.
Yes.
Yeah.
Yes.
Did anybody go to the class this morning?
Yeah.
Yes,
How was it?
it was good.
What did he talk about?
Hamotzi,
Oh,
a lot
And
about
Shabbos,
but what?
Shabbos, different things, different traditions of
traditions.
holding the cup and when you should be standing, when you should be sitting, when you're saying, making kiddush. Different traditions for different families.
Oh, okay. Okay.
Should I say good morning?
No, it's afternoon.
No, it's afternoon.
Is it really?
It's morning in
afternoon.
California.
So
morning.
Very early in the morning.
No,
No, it's
It's
9
morning in
o'clock, right?
Hawaii. It's morning in some places.
And 9 o'clock, I think it is in California, right?
9:30.
Or is
yeah,
it 5
yeah,
hours?
behind.
9:30.
It's 3 hours difference.
Right,
Yeah.
and Hawaii is 6 hours different, so it's 6
Oh,
in the morning.
oh, that's where my granddaughter is now.
Yeah, it's
Hawaii.
very behind.
Taiwan, it's 13 hours now.
Taiwan is 13 hours ahead, because my son was
Uh,
there for almost 2 years.
Right, right.
So it's, it's
It's
evening.
it's
there for him.
1:30 in the morning.
Yeah,
You have to figure out whether it's today or yesterday or tomorrow.
Yeah,
depending
my
on
son
the
is in
time.
Morocco, so I lost all track of
yeah,
time.
he's 7 hours ahead of you now.
as they
He's what,
say,
11?
Google it.
7.
Google,
7.
Google it.
Oh, okay. That's not bad.
Somebody has beautiful sunflowers.
Oh, that must be Iris.
Yeah.
Where is she? 30. You want to go out again? You want to go out again? The cat.
She's talking to her boyfriend.
Yeah.
She lets him out every once in a while.
Yeah.
Let him roam free.
Sure, it's a heat cat.
There is so much going on today with classes. And I go to a lot of the classes at RSSNY and Dorot. So I had to sort of in and out to get to everything.
The
Yeah,
good
I'll
thing
be
with
online
Zoom is
8
you
hours.
can go to multiple places at the same time.
I know, but you can't really exercise on the 3 that I go to on Monday and sort of pay attention to the lectures.
Oh,
So I sort of dropped, I didn't go to the rabbi's session and he changed his afternoon sign. So I'll go to that a half an hour later. That's all I can do because I have to keep moving through fear. I find that we're just sitting around all the time.
yeah. Karen, shall we start for the people that were on time?
May as
Well,
well.
I'm going to wait another minute or two because that's the way it usually is.
Oh, we
So,
start 5 minutes for the Jewish 5 minutes.
absolutely. So I'll wait.
I think you can start, Karen.
Well, let's give it another minute and then I certainly
We'll
will.
do the Jewish 5 minutes. Like Jews come late, but then they don't leave, so it all works out in the end.
That was my mother-in-law.
Yeah.
My husband used to say, start saying good night now. So,
Oh, at 4 p.m. in the afternoon.
right.
We used to call that the yucky goodbye.
There's actually a thing, it's called doorknob syndrome, and Jews suffer the most from it, where there's 3 goodbyes. The goodbye that's in the room where you've been entertaining, then the goodbye as you move towards the door, and then the goodbye when you actually cross the threshold. Because
Oh.
it's
I like that. That's interesting. Yeah.
When we used to visit in family in Montreal, and we'd get the kids zipped into their snowsuits and ready to leave, and my husband would still be saying goodbye for the next 10 minutes. It's a good memory that you just brought back. It's really
Yeah.
funny.
Okay, well, we're going to say good afternoon, everyone, not goodbye just yet. Today's speaker is Tobi Ash, RN, BSN, MBA, and she is completing her Ph.D. in health promotion. For more than 25 years, Tobi has been teaching, mentoring, researching, and helping women and girls with healthcare issues. Tobi has written a book and multiple articles on vaccination for different state and city health departments and the Centers for Disease Control and Prevention. Tobi looks forward to making a major difference in the health of all people with competent, compassionate care. Welcome, Tobi.
Thank you. So I'm going to start out by saying that I know that worrying works, because literally 90% of the things that I worried about never ever happened. So keep on worrying, everybody, because it does do the work, the job that it's supposed to do. But I'm here to talk about, we're 3 years into COVID. Everybody, if you can mute yourself, and I don't know how to mute everyone, but if you can mute yourselves, that would be amazing. At the end, or if you feel inclined, you can just unmute yourself and then just ask me questions, but I'm going to leave definite time for you to ask me any sort of questions.
If the
Karen,
host
as
could,
a
the
host,
host
you
could,
can-
could do it.
Yeah, the
Whoever's the
host can
host.
mute everyone.
Karen, are you the host? Is
I'm a
No.
host also, but I don't see where it is by me.
Melissa is on the screen. Ladies, just mute yourself. We've all been through this for 3 years. You know how to do it. Thank you.
Thanks. Okay. So today I want to take you on a little journey. We're going to go back to about 3 years ago. We're going to go back about 100 years ago, and then we're going to talk about where we are right now. So 3 years ago, in November, actually, of 2019, I started getting weird texts that people were seeing very odd flus in certain select emergency rooms in places that had like a larger Asian population. And in China, they also started noticing this weird flu. In Italy as well, because Italy does an enormous amount of trade with China in the production of things. And then, as you know, there was a lot of chatter in February of 2020. And then in March 2020, pretty much the whole world shut down. And this virus is based off of a virus that we've seen before, but it had a very virulent, that means a very, very powerful effect on people. So I want to just go into what a virus is very, very briefly, because if you understand what a virus is, then you'll understand how the vaccine technology works. So a virus is an infectious microbe. Microbe is kind of like a germ, but it's a little tiny fragment, and it's surrounded by a protein shell. Think of an M&M with a peanut in it, and how it has that hard shell, but there's something inside that is very active. But viruses can do nothing until they're in a living being, in a living cell. This is why you hear about viruses that lay dormant for a long time, and then they can cause some harm. So why I'm giving you this idea is that fragment that's inside the protein shell has either DNA or RNA in it. And it gets activated when it's inside a human or an animal living cell. And its job, it doesn't care. It infects the cell, sometimes to its detriment, because it actually tries to harm the host cell And so what ends up happening is that this is like measles and the COVID-19 virus or the SARS-CoV-2. Smallpox is another virus that does this, that it causes tremendous harm. So as soon as we saw the virulence of COVID, and it was terrible. I'm sure you all remember, nobody really knew what to do. And I know that it sounds terrible because we are so technologically advanced. So we were using what we thought based on the symptoms that we're presenting. And I'm sure you've had this before, that the symptoms present a certain way, but where it's originating from and what the cause of it is may be a little different than the symptoms that are showing. Like sometimes people have upper shoulder pain, but it's originating from the hip. So it's that kind of thing. So we had a lot of scientific work that started happening. And what was happening is that we were watching science unfold in real time. Most of us get information once all the experiments and everything has been done, and then we get the end product. For example, like all the work that I did with vaccines, a lot of vaccines take 10 years to develop. And that's not because they didn't know right away. They did know right away, but there's a lot of onerous steps in the middle that just take time, that are not even really necessary. But this is what happened 3 years ago and in the last 3 years that have made a problem. Because we were watching science unfold and we were using novel vaccine technology. By novel, I mean, we started working on the messenger RNA, the mRNA vaccines in 2009, but we never really deployed it on a large scale. So when people heard this, that we were doing this, some people got really nervous. But there was a gap of time until we kind of figured out what we were doing, until the real vaccine was rolled out. The vaccine was rolled out in December of 2020, which is very fast. And then we started giving it to everybody starting in the beginning of 2021. That gap of time created an issue. And this is what I want to talk about a little bit. There were political and social issues, economic hardships, social isolation, and anxiety. And that gap of time created an opportunity for a lot of misinformation and disinformation in very specific communities. And some of those communities I actually work with. So many of these communities already had a sense of distrust. And when they kept seeing all of the way science unfolds with like, maybe it's this, well, let's try it. And no, it wasn't that. And if any of you have ever made up a recipe, you know that you kind of have to try different things until it comes out perfectly. And that there may be certain factors that change how the outcome is. So when you're watching it in real time and people who maybe aren't really sure how things work, when they see these issues cropping up, it creates a situation where a lot of mis and disinformation can ferment and cause more issues. Can somebody mute themselves for just a bit? Now, I want you to keep thinking of questions for me because I'm going to be talking a lot. So you can write them down or even just ask your question. I'm going to go back 100 or so years ago to the Spanish flu. Now, the Spanish flu, when it happened, was absolutely devastating, kind of on par with what happened with the COVID-19 virus. Now, the reason that I say this is the amount of deaths that were attributed to the 1918-1919 virus were more than 50 million people. And so far, we are at a little over 6 million people worldwide, 1,070,000 confirmed COVID direct. In other words, COVID caused the death in the US. So it's not necessarily a true comparison, but this is the comparison that I want you to understand, and it'll help inform where we're going. When this virus came out, the world had a lot fewer people, but people really did live together, multi-generational households. It was just after the First World War. There were a lot of these factors that we saw the ways the COVID virus zoomed through certain communities and caused so much havoc in places where families lived very closely together, where it was multi-generational with young kids and older adults and all that kind of stuff. What happened after the virus is that several years later, it took about 2 or 3 years later, there were a lot of phenomenal advances that actually changed life projections for many people. Some of them related to hygiene items that we just take for granted, like running water in most households, the change in sanitation practices pretty much throughout the US, and life expectancy shot up. And that was because we changed certain ways of doing things. So what I'm excited about with this virus is that for the first time in a very long time, scientists are looking at airborne diseases, airborne viral illnesses, because those are the ones like we're seeing with COVID now. And they didn't know this then. There was a lot of resistance for calling it airborne. They thought it was droplet, and I'll explain that in a minute. What was happening is that people, now that the scientists are working on airborne, you have to be so careful. The only way to protect yourself against airborne is to wear a very specific kind of a mask and not really see people, not be around people that much. You have to be very, very protected for airborne viruses. For droplet viruses, which are, I'll give you an example. Airborne is, I'm in this room right now and I'm talking. You've all been in situations where somebody's talking and by mistake, they're so full of saliva that maybe a little spit came out at the same time. It doesn't usually happen, but when it happens, you realize how much water and stuff is in somebody's mouth. So when they're talking, this airborne stuff comes out. Now, when somebody sneezes, and you may have seen pictures of the velocity and what comes out with a sneeze that's not covered or protected, you know a lot of stuff comes out. That's also airborne. It stays in the air. You can't not breathe the air. Droplets are, I sneeze, stuff comes out, and the droplets settle. And they lay on the table, they lay on the doorknob, they lay on a surface, and then I touch it, and I was like, oh, my eye is itching, my nose is itching. You stick your finger in your mouth. That's how droplet-borne illnesses. So when COVID first came out, people thought it was droplet-based, and that's why they said, wash your hands. We noticed some amazing things that happened when most people were in a form of quarantine or social isolation and washed their hands and wore masks. Many, many viruses that wreak havoc stopped, literally. There are very few statistics for flu. And with flu, we don't count children that are above a certain age and adults that are below the age of 65 if they're very, very ill or that they unfortunately pass away from flu. We don't keep statistics for, we'll call it adolescents all the way to 65. We only keep statistics for people that are older or very, very young. We had nothing. It was amazing. So we know that these strategies help for sure with droplet and for some airborne. So that's why I'm excited that in the next few years, there's an enormous amount of research that's going into looking at how airborne illnesses can be mitigated. They can be stopped, they can be adjusted, and that will be amazing. Now we're going to talk about the COVID vaccine itself and why we're suddenly needing millions of boosters because, well, not millions, several. And this is a point of contention with people who have, we'll say, misinformation or disinformation related to the virus. So now you know that a virus has an infectious little microbe that's composed of RNA or DNA, and it's surrounded by a protein shell. Have any of you ever cooked an egg? You know that a protein is normally, or you've made meat, it's quite wet, we'll say, it's moist, and it's kind of smoothish because it's wet. And how you change a protein is you add heat to it. So when you cook a raw egg, it turns hard, whether you're doing it in a frying pan or you're doing it in a pot. it changes the texture and the ability for things to enter in. That's why they tell you, if you're making a beautiful brisket or whatever, and you want it to have a flavor, you marinate it and you add stuff into it, or you pound it, or you change it so that things get absorbed into it. It's very hard to absorb things. This is why the body will try to make a fever in response to a virus to heat up the protein shell of the virus so that it doesn't cause damage. It doesn't try to enter the cell and cause damage. That's why people get sick, because their body's trying to fight off this virus that's taking place. So now, here we come to the COVID vaccine. One of the big controversies that's being fought out now in the scientific world is, does the COVID infection itself provide robust immunity to people who do not want to take the COVID vaccine? And you can see this because I know in New York, there's been a backtrack in employees who were fired for not taking the vaccine, that now they have to be rehired by the government. So what is that all about? They were not sure that people could develop good immunity to COVID if a person had COVID, because the way immunity would work with this virus wasn't so clear, even till I would say this year, because we're measuring things as things are unfolding. It's kind of like being in a storm and thinking, like, how are you going to mitigate it while you're in the storm itself? It's very challenging. So one of the things that they decided to look at is, yes, we know that COVID itself can provide immunity. The problem is that we don't know how much COVID a person is going to get when they're exposed to it, the dose. And this gets us to how vaccines, especially for COVID, work. And I'll go into that a little bit, and then we'll go into long COVID, because it's all associated with this. So when a person is exposed to COVID, we don't know what other things they've got going on in their body, how well or healthy they feel naturally, their age, or any other things that they have. We don't know the dose that they're going to get, and the dose is one of the most important things. With the COVID vaccine, the doses are completely and utterly calibrated, that when a person gets the dose of the vaccine, there are some people that are reactive to it, and that's okay. That means that if they had gotten COVID, their reaction would be even more so. The doses in the COVID vaccine are calibrated to cause a reaction in the body to create a response to the protein shell that's on the outside of the vaccine, because we can't enter that protein. That protein is very tough, but we can damage the protein so that, or create a competent protein in the body, which is what the vaccine does, that recognizes this new protein as an invader and says, hello, you can't come in here. And that's how that works. So we know that people who've gotten the vaccine, most people, their arm will hurt, maybe a little red. We know that people have gotten ill from the vaccine. However, usually and almost always with the vaccine, the amount of side effects they're going to get do not last more than for 48 hours. That's with the vaccine itself. I'm not talking anything else. So now we know that the immunity that we build up to this particular virus, and it's called novel, not because it's pages long like a novel, but because it's new and we haven't really dealt with this sort of virus before, that is a shapeshifter and mutates so rapidly into ever evolving things. So the pandemic portion of COVID, where it caused multiple deaths and multiple and serious illnesses in many, many people worldwide, more than 685 million people in the world had a form of COVID. We're not even talking about people who had it that may be asymptomatic. We're talking about people that were ill, that sought care, okay, around the world. We're thinking now that as it evolves and as the pool of people who are vaccinated and who are boosted and who may or may not have had COVID, that layering of immunity will help to make it endemic. And that means that it will be with us, but it'll become kind of like the common cold. The common cold is also a coronavirus, not named after the beer, but corona meaning crown, because it has all those little spikes like a crown would have, and that's what's causing the issue. So we've all had colds. They're disruptive. They may make you not be able to sleep very well. They're troublesome, but they are not devastating. They don't cause this level of destruction that we saw for the last couple of years. So the World Health Organization decided to name the variants after letters. So you saw Alpha and Beta and Delta. Omicron.
Do I get it now?
Somebody mute yourself. I don't know who it is. Omicron is the most divergent. What does that mean? It keeps changing.
Picture disappeared when you put on.
For every single mutation that's new, we need to figure out how we're going to mitigate it.
Okay,
So one of the things, kind of like that we have with the flu shot, is we have to kind of figure out which variant
Did you get it
can be a
on?
problem. I think it's Anita. Anita and Cantro, are you able to mute yourself? So what's happened is that,
Oh, you have to mute that.
yes. So what we need to do is the World Health Organization, in conjunction with all of the different health departments around the world, look for variants. And they have what's called a variant. Let me see if I can do it. I don't know how to do it here. They're called variants of interest. These are the ones that we're looking at. And then we have variants of concern. Right now, we are looking at different ones of the Omicron variant that are causing, they have a very high contagion rate. And even people who are extraordinarily careful and people who have been boosted multiple times, and like Dr. Fauci or the president or the head of the CDC, they've been boosted, they're very careful, and these variants are extraordinarily powerful and very, very contagious. Now, even though Dr. Fauci is like approaching his 80s or in his early 80s, and the president is also an older gentleman, they fared fairly well. And the reason is because they had that layered immunity. Did they get sick? Yes. Did they test positive? Yes. But they were still active. And that's what we're looking for right now. We are still in the baby stages of trying to figure out the contagion rate of this virus and why it affects certain people much, much more. So we know that people who are older, and not that age is necessarily the factor, but it's people who have other issues, people who have type 2 diabetes or even pre-diabetes, people who are overweight, things that normally wouldn't be a big deal are kind of like a risk factor. So as we get more information, we're able to make changes and things like that. So because, and I don't know how to say this nicely, but because there was very big resistance in creating, we'll call it community immunity, with a robust uptake of the original vaccines, and this was worldwide, and we have an open world where people travel, so we can get new variants from different places. We had a situation where some of the companies, Sanofi and other vaccine manufacturers, are working on new vaccines that are based on proteins. It's not the mRNA vaccines. These are what we would call old line vaccines. This vaccine technology is well over 100 years old. And because they recognize that 25% of people have needle phobia, what ends up happening is that they won't take a shot because they're very, very scared. So they're working on, and they have this with live vaccines for the flu for some people who can take them, a nasal spray or what's called a mucosal style vaccine. And there's even work being done on a vaccine that's like a Band-Aid that you put like a Band-Aid. It's called a microarray patch, and you put it on for a little bit, and it gives you a robust immune response in your body without having to inject yourself. There's also work being done on what's called a pan-coronavirus vaccine that will stop virtually all coronaviruses. But where we are right now is that just like with the flu shot, we're trying to anticipate which variant of concern or which variant is that we're looking at right now is going to be the variant of interest that's going to be the one that's circulating right now. And we never know. And that's why sometimes even with the flu shot, sometimes it's like 60% effective. And there's been times in years where it was 20% effective, but I still take it because I've had the flu unvaccinated and I almost died. And so I know I want that protection. 20%, if I see something that's 20% off on sale, I'm buying it because that's a really good deal. So that's how we have to think. So vaccines work, and they work well when everyone is on board. Now, there are some people that cannot take a vaccine, either because they are allergic to one of the components that they use in making the vaccine, or because they have true needle phobia and they won't do it no matter what, because they're really, really scared. So I'm excited for these new technologies, because what they'll do is that they'll boost up the person's immune system, and they won't be what we would call, very not nice name, but a reservoir of disease. The more people that have immunity, the better off everybody will be. As an aside, we do know now that when people do mask, and they mask appropriately, I'm not talking about a really fancy mask with like, bedazzled with gems and everything that is made out of fabric, that will not give you the robust protection that a proper mask will wear. Even surgical masks can work. I met a lot of people who are like, I don't believe in that and whatever. And I said, fine, but the next time, maybe God forbid you have to have surgery, I'll tell your surgeon doesn't have to wear a mask because you don't believe in it. So, and that's the whole concept. Why are masks important? Masks are important not because of the other person. It's with surgical masks, which is what they wear when they're doing surgery, is because it protects the other person against what you have. But if everybody's protected from what you have, you'll be fine. You'll be okay. And we saw that with so many other communicable diseases that I know for the scientific and medical research world, we were super, super excited about that. So now we're going to go into long COVID. Actually, before long COVID, I want to go back a little bit and tell you about the 4 Ds of vaccination that will give you an idea of the challenges that people in the vaccine world have. The first D stands for dose. How much, we'll call it germ, can we put into the dose that will create a great immune response for millions and millions of people without causing harm to some of the people that are taking it? That's the first dose, number 1. And number 2, how are we going to give it? And this is important because remember I was telling you about the new vaccines that are being worked, like the Novavax? The reason those are exciting is because those doses that are based on old line, we don't need to do as much work with them. And I'll explain to you with the next D, which is delivery. The delivery of a vaccine means not just putting it in the arm, but how do you get it to the doctor's office? And we've all heard that there were hospitals or like clinics that received the new vaccine, but they had to waste it because it had to be kept super, super cold and at certain temperatures, and it had to be given in a certain amount of time. also with delivery, then it also has to be how often do you give it? Like now with COVID, with the newer boosters, first they said you have to wait 2 months after you got a booster or you had COVID. There's new evidence that's literally brand new. It just came out in the last few days that says that maybe you should wait 4 to 6 months from having COVID, not necessarily having the vaccine, from having COVID. If you had a positive COVID test and had a serious level of COVID where you felt really under the weather and you want to take the booster, you may want to wait 4 months, doubling the time 2 months. And the reason is because your immune system is sorting itself out. Not that you don't want to overwhelm it. Right now, your immune system was overwhelmed with this virus. It's just that your body is creating a layer of immunity, and we don't want to mix in the other variant because we don't know which variant you had to the mix with the vaccine. But by 4 months, your immune system has that variant locked in place, that if that variant comes again, it'll say you can't come in. So that's the brand new thing. So delivery is, how are we getting this new vaccine with the dosing into the facility, whether it's a clinic or your doctor's office or CVS or whatever, and how are we giving it? So again, the optimal is the shot in the arm, which is for some people painful or they have a phobia. So we have these new incredible technologies that will be rolling out shortly so that people don't have to be scared. And just as an aside, we know that in countries where people have very big needle phobia, or you have to have needles and you have to have the medicine, that polio, which is, as you all know, is very devastating. They used to give it, and they still give it in most countries by mouth, not in the US at all, because it's simple, it's easy, and most people will take it because it's so simple and it doesn't involve any fear. We put food in our mouth every day, and we brush our teeth, hopefully. So we know it's comfortable for us to put things in our mouth. Okay, so we have the dose, we have the delivery. Now we have the demand. Demand is a huge challenge because most people are scared. They're scared to put a germ into their bodies. And it's hard for people to understand. What I find interesting is that people who do homeopathy will take something that's, I don't know if you understand the principle of homeopathy. So for people who are hesitant to take a vaccine, I talk about homeopathy a lot, because with homeopathy, you're taking the actual thing itself. Like if you're throwing up, you take something called Nox vomica. Vomica means vomiting, right? So you're taking a dose of it to stop what's going on. So, but how do you get people to want to do this? So most people that I know are very motivated not to be sick. I don't really know people who say, you know what, I'm just like so tired of everything. I would love to be sick and lay in bed. I don't really know people like that. So how do you motivate people to get this? So sometimes we have to do mandates, which is what happened, and they kind of backfired. But most of the time, what we want is for people to feel comfortable in mitigating what looks like a severe thing. What was shocking with COVID was the high death rates. More than 1 million people in the US died. And this is not COVID associated deaths, like people who developed cancer or people who delayed treatment for things, any of that during that time that didn't get timely care and passed away as a result. We're talking about deaths that are directly related. For some people, it wasn't enough of a motivator. So lastly, we come to data. And data is the most important part, and it's the most overlooked. I'm going to just talk a little bit about data, and then we'll go into long COVID. Data for how do we know everything that we know about COVID? So 3 ways. The first one is a person felt sick. They felt sick enough to go to their doctor. Their doctor said, let me test you for this thing, and says, oh, wow, it is COVID. And then the doctor reported it. So we have pretty good data for all the people that went in those lines by cars, or they went in those, huge COVID testing facilities. We have very good data from there. We have good data for people who sought medical care in hospitals. But guess what? We don't have good data today, because you could have, up until September 1st, ordered tests from the federal government to test yourself in the privacy of your own home. You were not obligated to report your positive test. And if you didn't seek medical care, nobody in the health department knew that you were unwell. So right now, our data is not adequate. So based on inadequate data, people have changed their lives to going back to 2019 and opened everything. This morning, I was in a medical facility. I was in a hospital. And I would say, except for a few people, nobody was masked in a hospital.
Right.
And this is what's happened. And this has happened because we're not tracking the data appropriately now. We have lost count of the data. The only data we really have are hospitalizations and who came into the hospital that was vaccinated or not, how many vaccines they received, and what their symptoms were right now. And we see that the death count has gone down, thank God. And most of that is due to layered immunity. I would like to see it better. I would like to see no more COVID deaths, but that's going to require more participation from a lot of other people. Let's go back now to long COVID. Long COVID is a real thing. And the people that have had chronic fatigue syndrome and Lyme disease are thrilled, because all of their symptoms that they've been complaining about for years that seem vague are now going to be taken seriously. The NIH has invested over $1 billion into long COVID, and it's ever evolving because there's a lot of stuff that we don't know. One of the main symptoms is breathlessness when walking upstairs, and this happens in people who are 20 years old. And part of it has to do with the way the immune system is responding. And I'm going to go into long COVID for a bit, and then we'll wrap it up and you can ask me any questions that you want. It's estimated that 1 in 5 people who had COVID experience 1 or more symptoms of long COVID. That is a lot of people. And it's an estimate because not everybody has contacted anyone, but it's for people who the symptoms, which range from breathlessness and absolute exhaustion, like fatigue, like real tired, like making the bed makes you tired, chest discomfort, cough that never goes away, that's not attributed to anything, joint pain, insomnia, dizziness, a dry mouth and dry eyes, not caused by anything else. PTSD is a neurological symptom. Impaired memory, poor concentration, and anxiety and depression are the neurological memories. So for a lot of people who have long COVID, there's a definite and distinct decrease in their quality of life. And part of it is that for most people, if they know what they have, they just feel better, even though they're still not well. They're just like, okay, now I know what it is. But for a lot of people, they don't know. So these are the concepts that we're trying to narrow down. Let me just, as an aside, we still don't have all the data, but we know that people who have severe COVID, who are taking Paxlovid, may have a better response to not getting long COVID. They're doing a study right now, a very large scale study, to see if that's true. So long COVID is diagnosed when you have that collection of symptoms that I read to you well after a COVID infection that lasts more than a month, that cannot be attributed to anything else. That means no medication that you're on that causes dry mouth, no heart disease that's making you tired, nothing else. It's just that you had COVID and then you have these symptoms. So this is where they're looking at to see how this virus makes people have this long-term sequela. Okay. That people who got really sick with COVID may end up getting long COVID. So in other words, if you lessen the COVID symptoms by vaccination, that you won't get long COVID. If, and this is the if, this is what they're looking at, if COVID itself, even asymptomatic ones, can cause lung problems or heart problems or harms the blood vessels, they're not sure. We don't know yet. I'll have to get back to you. If the initial infection affects the microbiome is the trillions of bacteria that live in your gut that help to mediate your immune system. Or, and this is the one that's gaining the most traction, if COVID, especially severe COVID, activates the immune system in such a way that it affects healthy tissue even after the infection is over. So I don't know if you've ever banged yourself, like you whacked your finger against something, right? The immune system doesn't just recognize foreign invaders, it also recognizes damaged tissue. And that's why, like, if you have a stubbed toe, it may get red, or if you bang your finger against something, that's your immune system at work. So what happens is, one second, espérate. So what happens is that the immune system sends cells that mend, they like sew things together. And that when they sew things together, that they don't stop. They kind of settle in an organ and keep thinking that they have to keep working. So while we want a really good immune response, we want it to stop when it's done. And scientists, especially at the NIH, are looking right now at how COVID is doing this, that it's continually making certain parts of the body respond as if the inflammation is still ongoing. One of the most troublesome things, and this is where I'll end, of COVID is the anxiety it produces in everyone. I am sure you've seen on TV or read in the paper or heard on the radio that the level of anxiety in the world has increased. And we can actually attribute it to COVID. Part of it was the social isolation, the economic hardship, or people thinking, I don't want to go to this wedding because I may get sick from it. And so that's anticipatory anxiety. But what's happened is that we know when the immune system is revved up, and we know this from people who have autoimmune diseases like lupus or irritable bowel disease like Crohn's or colitis, or lupus or rheumatoid arthritis or multiple sclerosis, that autoimmune diseases that affect the immune system actually change brain chemistry and create anxiety. It's not that having the disease and people are worried, it's that it actually has an effect on the brain and makes people anxious. So there's a theory that the COVID virus itself can create anxiety by the way it affects the immune system. So the bottom line of this incredibly depressing talk is that we need more studies. We do know in the scientific world that in countries where they had a much higher vaccination rate and that they did stop people from coming, from foreign countries, that they were able to arrest the spread of new variants. For people who were more at risk, like people who had autoimmune diseases, or for people who had other illnesses or older and were more sedentary, that they required a bit more protection. So if they wore masks and social events, they actually did fine. So we do know some things, but we don't know the other things. So I'm hoping that our society in the US will understand that we need multiple layered immunity and that it will make a difference in the health of everyone. So if you haven't gotten your booster, I suggest that you do. And if you're capable of receiving it, that you haven't had COVID, know that the new variants are extremely contagious, even if you do all of the strategies to protect yourself. I myself had COVID in September and I'm boosted and I wear a mask and everything. It's just that sometimes it can slip through because it is so contagious. We know now that it's airborne. So that means mitigation strategies include everything, and it still might happen. But if you have multiple layered immunity like I do, it really makes a difference. And that's why after it was over, when I tested negative, I was fine. So now it's time for you to ask me your questions. And before, I just wish everybody good health. And I know that everybody here is committed to living a long and healthy life. So question time.
So-
Yes.
I just want to say something, if you don't mind.
Sure.
Before we continue with questions, I would like to add one additional item to Tobi's bio, and that is that she is related to somebody we all know, our executive director. Rose Ziegler is Tobi's sister.
She's
Right.
a spitting image of her.
I know,
She's
I'm the
spitting
older
image.
sister.
Yes.
She's like my first child. I was 13 when she was born. She's like my first baby. So
Oh,
you know,
wow.
There were three sisters here, just like my mother's family. So, okay, sorry, I just had to.
Karen, you're in
interject.
charge because I don't know who everybody is. So you're the one who.
Okay, so I'm looking, Elaine.
This is just, I know someone who's had all the shots and has had COVID 3 times.
Yes.
Is that, I know it's not common, but is it more common than we think of?
It is not uncommon, which means it's not usual, but we have seen it. For example, we know for sure that about 5% of people will have COVID multiple times despite being vaccinated. And what if this might help you with this image. When COVID first started, they did not give nurses that work in the ER and in ICU normal PPE, like normal, like with the gowns and the masks and the everything. A lot of nurses got sick and died, but there were some impervious. They were fine. They dealt with 10 COVID patients, never even had a sniffle. So we know that some people are more, they're more amenable hostesses to COVID. And they're the ones that I like to want to give extra protection to, because if everyone around them wasn't harboring, then they would do better. Some people are just much more sensitive to this microbe than others. And those are the people, about 5% of people do get COVID multiple times, despite everything.
Thank you.
Helene, you have a question?
Yes. Thank you very much for pulling all of this together. I thought it was really a great presentation. My concern right now is New York City. Unlike New York State, unlike the whole United States, New York City has a very high level of COVID. New York City just in the past 2 weeks, 23% increase. We've seen this before with New York City, sort of almost like the beacon the rest of the country might follow.
Mm-hmm.
Any thoughts on why we're so lucky?
You're lucky because of all of this, just like London and like France and a couple of other places. But there's 2 things I want you to consider. Number one, New York does do tracking and data tracking. So it looks like New York is failing, but what New York is doing is telling the truth versus other places that are not tracking and are not keeping good data. So that's number one. It's not that you're a beacon, it's just that nobody else is keeping the records. That's number one. Number two, I can tell you right now, every single emergency room and certainly children's emergency rooms are overrun with different viruses. And there's this whole concept right now of what's happening with the immune system. Like, we suppressed everybody's immune system because we wore masks for 2 years and now everybody's getting sick. No, what happened is that these viruses were always circulating, but what's happened is that everything is heightened now. And because of mis and disinformation, and we'll and it's very unfortunate, but a lot of a political slant in the way healthcare is provisioned in this country has changed things. So the 23% that you have in New York right now is probably equal here where I am right now in Florida, maybe even higher. It's just not reported. What's happening is that that's why there's such a rush to do all these different vaccines that have a different, we'll say, staying power and bring a different level of immune response. So for example, with the flu shot, you used to get it in autumn and it would protect you all the way through spring. Now with the boosters, we don't think that they're lasting that long. It's not that they're not lasting that long. They're very precision, precisely developed antiviral, injection. The problem is because they're so specific, if there's a slightest mutation, COVID. So maybe that's why there's thinking that maybe we don't need to be so exact. Maybe we could be a little less imprecise and make it broader. And that's why they're calling it a pan vaccine, that it will create a different immune response that's not so targeted, because we're seeing all of these mutations slip through. And it's slipping through because we lived with certain variants for a very long time. Then Delta showed up. Delta was devastating. Now it's Omicron, and Omicron is literally like a chameleon or something that, like mercury, it changes constantly. And we don't know which variant is going to be the more dominant one. So we can't keep switching the variants. And that's why there's this work on doing that. But your thing about New York is excellent. Also, New York has a very deep concentration of people that live very closely in contact with one another. We don't have this rate in people who live in very rural, spread apart areas. It's people who live together, who do things together, are in the same space together. It's airborne. We know that now, and that's part of the problem.
Thank you.
Yes.
I have a question just to change vaccines on the polio vaccine.
Yes.
We've all had the polio vaccines when we were young, and there have been, I'm sure you know, a few cases of polio around the 5 boroughs in Rockland County.
Yes.
Mostly from people who never had the vaccines.
Correct.
Are the vaccines that we had so many years ago, are they still good?
Yes. Because first of all, everybody here, I'm assuming, was born by the 60s.
Yes.
Mhm.
Okay. So as a result, you received the oral polio vaccine. The oral polio vaccine, and some of you may have even received the inactivated polio vaccine. The oral polio vaccine basically confers lifelong protection against polio. What happened here in New York is an unvaccinated person caught what's called vaccine-acquired polio. Vaccine-acquired polio happens when a person is unvaccinated against polio, whether with the oral or the inactivated, the one that's given in the arm, and it can happen at any age. Polio is not just for little kids. Franklin Roosevelt got it in his 30s. People can get it at a later age. What happened is that they did, they were near wastewater or something where polio lives in waste and wastewater, and then they caught it. Everyone here that received the oral or the inactivated is 100% okay. You don't need a booster right now. You do not. That's the consensus of the health department. Yes.
Well,
Karen, you have to help me.
Gail, go ahead.
Is there any truth to the concept that people with type O blood are more immune to COVID?
They have, they're looking at that because remember, on your blood, what makes you O, A, B, or AB are proteins. And because of the protein shell of the virus, the proteins allow in. Have people with O positive blood passed away from COVID in the early days? Yes, 100%.
Yeah.
But they have found that certain blood types they may not have it as severely, but still that's no protection. I have O positive blood and I got COVID twice. So
Twice.
it's not necessarily a get out of jail free pass
And
card.
are you also hearing that this new booster may not be as effective as they had hoped?
Yes, and that's because nobody was expecting this new wave. They monitor waves around the world. Like you may have heard, there's the South African wave and there's the wave from France. There's many different variants of Omicron. A lot of them are starting with a B, which doesn't make sense because if it's Omicron, it should start with O, but who knows? I don't run the World Health Organization. The different variants, some of them are highly, highly contagious, but not so dangerous. In other words, like people feel sick, but they're not like they can't breathe. But they're seeing that this is the thing. The more precise the vaccine, and if the person is that's the one that is entering them, it's perfect. It's like a lock and a key. It's great. But because we can't control which variant and we don't know which is the one that's coming, that's why they're modulating the thinking. So there's a newer vaccine that's coming out now, like a bivalent style, that they have very great hopes for. It's looking very, very good that people who are exposed to some of the more virulent variants are doing very, very well with it. So I'm very hopeful for that.
Thank you.
But right now, it's not such a great match.
Thank you.
Sandra?
Yes.
Sandra, go ahead.
How long does the virus airborne stay in the air?
They're actually looking at that. Most of the time, airborne viruses stay for about an hour or so. I'm not sure of the data because if you remember, I would have to get back to you on that. If you remember at the beginning, they said it wasn't airborne, and there's still people in the scientific world who are fighting this for some reason. And so they're not sure. I've seen where it says 2 hours. That's why, like for me, if I'm going anywhere that's not at home, I'll wear a mask. I'll wear a mask because I don't know. And what happens when they measure the viral quantity is which variant are we talking about? So, and when variants are changing and there's constant mutations and I don't know who I'm with and all of that, I don't know. So for me, if I'm going to be in a public place, I'm going to wear a mask.
So I have a question on the third booster.
Yeah.
If a new vaccine is coming out, that's better than supposedly better than all these boosters, does it pay to get the third booster if you haven't gotten it yet, or wait for the new one?
It depends on your risk. In other words, if I mean, the third booster has been around for a while, and it hasn't shown, like I got it, and I got COVID fairly soon after. So this is why I'm not sure, because I don't know the timeline and if the approval will come through on the bivalent, when it's going to come out. I would say it's always better to be protected. If you haven't gotten the booster yet, I would get the booster, just because right now the flu season, RSV, all of these respiratory viruses that are very, very, they're out there and they're affecting many, many people. I know with the flu has been very bad already. So I would say, even though I like the new bivalent much better, I would recommend that if you haven't gotten it, to get it and then lay low and then wait your doctor. And it's always good to speak to your doctor, because I don't know any of you personally. And so I would ask them for their opinion in reference to this, especially with the new considerations that they're saying to wait a little bit longer. But because we do know what the boosters have, and we do know what the new bivalent, the strains that they're looking at, that maybe they'll let you get it a little bit earlier, and then you'll be fully protected.
Okay.
You have one more question, and then Sandra.
Yeah. Why do some people get such strong reactions to the virus and other people get no reaction?
And that's a fantastic question. And right now we don't know, like even with, let's say, smallpox or other viruses, some people would just get it. Like the whole concept of vaccination came about because girls who would milk cows never seemed to get smallpox. They had all been infected with cowpox. And that's when Jenner came up with this whole concept that maybe giving people a form of cowpox would protect them against smallpox. And that's where it was called variolation. And that's why it's called vaccine, because vaca means cow in Latin and Spanish. And that's why we call it vaccine. It's named after cows. Essentially, we're all domesticated animals. So basically, we don't know. It's a great question. It's a great question because different people get different viruses. You can see in your own family, if you raise children, to me, I love them, but they're reservoirs of disease. And sometimes the mom was fine, but everybody else in the family got the cold. We don't know. We do know for droplet-borne things, good hand washing, and that means friction, does help enormously. Enormously.
Well, thank you, Toby. Really, this was great. We're going to have a follow-up on this somewhere down the line when you have all the new information for us.
Yes.
So I want to thank you and thank everybody that participated in today's program.
Thank you, everybody. I bless you all with excellent health, and
And to you too.
yes, let's make a difference in the world, by being healthy and showing people what health looks like. All right. Take care,
Very
everyone.
good. Thank you. It was very
Thank you.
interesting.
Bye-bye, everyone.
Bye.
Bye-bye.